I'm so happy to see a larger crowd this year, and I am so excited of the sessions that we are having today and the work that we will be doing, not just from today on, but all the work that's been done in the past. I do want to recognize the staff of Ryan White Services and Resources. They've done an awesome job in really working with the presenters, getting all the agenda items together, Fast Track Cities members helping to plan the event, and also AETC. And many of you that, I can't think of the names right now, but this summit is so important. This is our second Stigma Summit, and we would not be able to do it without Ending the HIV Epidemic grants and without your participation and commitment. And what I'd like to do is introduce Dr. Jennifer Avegno. Dr. Jennifer Avegno is a New Orleans native who received her undergraduate degree from the University of Notre Dame, a Master's of Arts in Sociology from Tulane University, and her MD from LSU School of Medicine in New Orleans. She completed her residency at LSU Charity Hospital Emergency Medicine and joined the faculty at both LSU and Tulane shortly after graduation. As an academic faculty member, Dr. Avegno worked in medical education and established a division of social emergency medicine at LSU to facilitate innovative programming, interdisciplinary partnerships, and improve population health outcomes. In 2018, she was appointed as the director of the health department for the city of New Orleans, where she led the city's public health response to the COVID-19 and Mpox epidemics. At NOHD, Dr. Avegno manages a dedicated team of public health professionals in addressing critical health needs for the community and with intentional core focus on social drivers of health, equity, and access. And that includes our team at Ryan White Services and Resources, and we are so happy and proud to have her as the director of the health department. Dr. Avegno.
I'm really honored to be here today again for the second summit, and I don't know, I feel like it's doubled in size from last year, so we're really excited to see old faces and new faces in this lovely clinical setting. And I really do want to thank the dedication and hard work of our staff at Ryan White every single day for keeping HIV and AIDS care, treatment, stigma, breaking down barriers, foremost in the mission of the health department and the city. I bring greetings from the mayor, who couldn't be with us today, but as many of you know, this is a topic that is really important for her, and she's been a vocal supporter of the community's work to end the HIV epidemic for a very long time. And thanks to you, our partners, our community, we've made some real progress in reducing new infections, improving access to care, and promoting health equity for those living with HIV in our community. I was excited to read the most recent report this week that came out about the state of HIV in Louisiana, and I was even more excited to see that, because I'm a numbers person, so I love numbers. Over the past 10 years, we've reduced the number of new HIV diagnoses in Louisiana by almost 25%. That is a lot, right? And that is hard work, grinding it out by everybody in this room and many more. We've increased the percentage of people who are aware of their status. We've improved the linkage to care and viral suppression rates such that as of last year, 88% of people living with HIV in the state are virally suppressed. That is tremendous. When I began my career, not in this building, but in the old building down Tulane Avenue, really at the height of the HIV/AIDS epidemic, I never could have imagined that almost 90% of people would be able to be living with HIV as a chronic disease. So that is some tremendous results. And they're a result of our collaboration, our comprehensive approach to HIV prevention, expanding testing, expanding PrEP services, enhancing linkage and retention to care, supporting medication adherence, supporting viral suppression, and really addressing the social determinants of health, which we know are so critically important to keep people in care and keep them healthy. Reducing stigma is yet another, reducing stigma is yet another part of this great work. We've leveraged data and technology to monitor our progress, to identify gaps, and to amplify the importance of testing and awareness through our Bounce to Zero campaign and all the other messaging that we do. We are not complacent, though. We know that we still have a lot of work to do. There are still challenges and disparities that we need to address. We know that we have some populations who remain more vulnerable and more affected by HIV. And we know that barriers in accessing and staying in care are still present. Lack of insurance, transportation, housing, mental health, substance use services, all of those continue to be major challenges for those that we serve. And we know that stigma and discrimination still, after all these years, are pervasive and persistent, and they affect the quality of life and the well-being of those that we care for. So that's why we remain committed to continuing our efforts to achieving the vision of ending the HIV epidemic in New Orleans by 2030. That's 6 years away, 6.5 years away. This is an ambitious target, but we can do it, and we're going to move forward with determination. To do that, we're going to need everybody's continued support and collaboration. We need to continue to work together as a team, as a community, as a region. We need to expand and share our best practices, learn from each other, leverage all of the amazing collective expertise. We need to innovate and adapt and evolve as the HIV landscape changes, and as we know, it changes very rapidly. But always, always, always keeping the focus on those that we serve, their voices, their needs, their preferences. So I love to look back and see how far we've come, and we really have come a long, long way since the very beginning of the HIV epidemic. We've shown resilience and courage and determination like we always do in South Louisiana. You all have definitely saved lives. Always remember that with the work that you do. You've improved the health and quality of life for others, and you've made a difference. But we're not done yet. And I hope that today we're going to hear more strategies, more stories that's going to inform the work to come. So to kick off the day, I'm really excited to introduce our incredibly accomplished keynote speaker, Dr. Linda Koenig. She's the Senior Advisor for Research to Practice and Partnerships in the Division of HIV Prevention at the Centers for Disease Control, the CDC, where she leads efforts to strengthen interagency partnerships, enhance implementation research. Is that on? She brings evidence-based practices to scale. From 2013 to 2021, she served as the chief of the Prevention Research Branch in DHP, where she oversaw the design, implementation, and evaluation of HIV prevention interventions, formative research, systemic reviews of the HIV prevention literature, multi-site demonstration projects, implementing high-impact prevention through health departments. During her tenure at CDC, she supported multiple public health efforts, including being the lead for disaster mental health, which we in South Louisiana know is a critical need. She's been the chief of the HIV Prevention Communication Branch. She's published widely, and she's known for her expertise in HIV in youth, medication adherence, patient navigation, mental health, and the intersection of HIV and violence. She's a licensed clinical psychologist and a fellow of the American Psychological Association. She graduated summa cum laude from Macalester College, received graduate degrees from Northwestern, did an internship at Ohio State School of Medicine, and was an NIMH postdoc fellowship at Stanford. Wow. Prior to joining the CDC, she was a psychology professor at Emory, where she taught undergraduate and graduate courses and served as director of clinical training. So let's give Dr. Koenig a warm New Orleans welcome.
Thank you for that lovely introduction, and thank you so much for inviting me to be here with you today. I'm really sorry I can't see you guys on the other side because I'm short. I'm not taller than the screen. And I'm excited to be here and share with you what we're doing at the CDC around assessing and addressing HIV-related stigma in the United States. So this is a little outline and overview of my presentation today. I want to start with a little bit of an overview on the concept of stigma. I know you had some of you attended a training, and so maybe it's something you already know, but I just wanted to share where things have been moving with the whole concept of stigma, to talk a little bit about the impact of stigma in HIV care and prevention, and then turn to some of the work we're doing at the CDC to measure HIV stigma at the national level through our surveillance projects. I'm going to talk a little bit about changing attitudes through social marketing, some of our stigma reduction work, and then finally talk about some of our large public health strategies for HIV and how I see them as sort of collateral stigma reduction interventions, not directly targeting stigma, but having stigma reduction as a benefit. And I'll finish up talking a little bit about the importance of language and community voices. All right, so starting with the concept of stigma, many of you are probably not as old as me, but I remember back in college studying Dr. Irv Goffman, who originally defined stigma back in 1963 with this seminal work, in which he describes stigma as having a spoiled identity. When someone with an attribute that's deeply discredited by his or her society is then rejected because of the attribute, that's how stigma was defined. And despite the 60 years in which this concept has evolved, there are some key elements that are still relevant today. And two I want to point out is that stigma is inherently social. It involves a social identity that a person has or adopts, or it could be a social role that they are expected to fill. And it's a dynamic process. It's something that's not, it has to be an interaction with other people also in that social world. But of course, in 60-some years, the concept's evolved. We now think about a wide variety of stigmatized conditions, and we know there are stigmatized groups. Some of the common stigmas we see include those that are associated with cultures, with gender expression, sexual orientation, with race, with ethnicity, and even illnesses are stigmatized. So of course you probably know that HIV/AIDS remains one of the most stigmatized diseases. There are other stigmatized diseases, and some common comorbidities with HIV are also stigmatized conditions. So mental illness and substance use disorders, there's high comorbidity with HIV and AIDS, and mental illness is a stigmatized condition. And other comorbidities like STIs and viral hepatitis are also stigmatized conditions. I'm going to talk a little bit later about what happens when there are someone's identity encompasses multiple stigmatized conditions or identities. There are often many, many types of stigma that people talk about, but the big three are internalized, enacted, and anticipated. Internalized stigma means that the negativity from the social environment has been absorbed by the person. They're taking in that negative social attitude so that it's coloring their view of themselves, might include self-blame, and include some low self-esteem in relation to that stigmatized condition. Enacted stigma, it could be real, it could be perceived, but it always involves some sort of public interaction. So it's something that's happened or something someone has believed to have happened in a public sphere. Either they've received unfair treatment or perhaps a microaggression, a comment that's negative, or downright legal discrimination. And anticipated stigma is really a projection of what's going to happen in the future based on having that stigmatized identity. So it could be fear of gossip. If people talk about you, if they find out you have HIV. It could be negative comments that are made, perhaps about your sex life or your choice of sex partners. It could be blame if you had only taken care of yourself. It could be potential rejection. You don't want to start a romantic relationship because of an anticipation that you will be rejected, or even experience violence when someone knows you have HIV. If you follow the literature, today we generally talk about intersecting stigmas or the intersectional nature of stigma. And that refers to the fact that there's a convergence of multiple stigmatized identities within either a person or a group. And this creates a very unique experience because you're really looking at the joint effects of these different stigmatized identities. And it's these joint effects that have profound impacts on health and on mental well-being. So when we say HIV stigma, we're talking about negative feelings and negative beliefs associated with having HIV or AIDS disease. But as I said, HIV stigma converges with other socially stigmatized identities for many people who have HIV or have risk factors for HIV. So minority race, ethnicity, sexual orientation, and gender identity could be a second condition or situation that someone is experiencing. Living in poverty, using drugs. These are all converging experiences that overlap with HIV, either having HIV or even needing HIV prevention services. So why this is important is the intersectional framework moves us from focusing on individuals to thinking broader about systems. So these multiple categories, they intersect at the level of one's personal experience, but they also reflect larger macro social systems of disadvantage and oppression. So it changes us from focusing on the stigmatized person to the stigmatizer. What are various stigma practices that are happening? Stereotypes that people have, prejudices that people have, and discriminatory attitudes. And then it encourages us as clinicians and researchers to take a look at larger systems. So structural barriers, structural policies, norms that are maintaining these stigmatizing attitudes and systems of disadvantage. And of course, as a researcher, it requires us to have more complex measures to truly assess what's really going on in stigma and interventions, and that is the challenge that we're having. Okay, I want to give just a few examples of the impact of stigma on HIV care and prevention. There's been a lot of research on stigma within HIV. Stigma is associated with lower levels of HIV knowledge, engagement in testing and prevention services, adoption of preventive behaviors like PrEP or condom use, disclosure of one's HIV status, engaging with routine health care, adhering to ART, and then, as a result, lower viral suppression. This is a stigma framework that was introduced by Valerie Earnshaw, and I wanted to present it because what I think is really helpful to think about is that, of course, stigma impacts people with HIV. It impacts HIV and continuum of care outcomes, so it may impact engaging in care, adhering to medication and viral suppression. It can lead to lower social support and mental health and distress experiences and mental health conditions. But it also impacts people who do not have HIV. So if you have these negative stigmatizing views about HIV, it will cause you to distance yourself from people, to be potentially a stigmatizing person through your attitudes. But it will also impact the likelihood that you'll get tested for HIV because you don't want to find out that you have HIV. It might mean then that you get diagnosed with HIV later than earlier if you have undiagnosed HIV. It may lead to not utilizing PrEP for prevention as well as any other prevention strategies. So it really impacts more than just those living with HIV. And as I said, there's been a lot of research, enough to do a systematic review. And in this systematic review by Sweeney and Vanable, they showed that there was a lot of links between internalized stigma and ART adherence. And I want to spell out some of the mechanisms and processes that link these two together. So synthesizing across many studies, this review found that the association with ART adherence is more consistent for internalized stigma and anticipated stigma than it is for various enacted stigmas. So the link seems to be with internalized and what you think is going to happen. In almost all the multivariable models that they looked at, depression symptoms were among the variables that were accounting for the relationship between internalized stigma and poorer ART adherence. There's a number of ways that depression can link these two: a lack of self-efficacy associated with hopelessness, poor disease management associated with lack of concentration or cognitive or memory difficulties, poor organization skill, low energy, and also fear of disclosure and not getting social support. Now, these data come from our MMP, our medical monitoring project, and I'll talk about that more in a minute. But I just wanted to say we use that to measure HIV stigma nationally. And we know that among people in HIV care, almost 80% reported feeling some internalized HIV-related stigma. And women report experiencing more internalized stigma than men. We find this in our MMP surveillance, but also it's there in other studies. And I'd like to share this example. I'm going to give just a couple of examples from the stigma literature, one for women and one for men. And I'd like to share this one from the research of Janet Turin and her colleagues at UAB. Because they did it with, they looked at the relationship between internalized stigma and depression and ART adherence among women living with HIV in a very large cohort. This is the WISE cohort. I don't know if you're familiar with it, but it's the largest cohort of women living with HIV in the US. It is sponsored by NIH. It's been replenished, but it's been going on for decades, actually. So it's a very nice large sample. And what they found in their cross-sectional data were that loneliness and depression and low social support were mediating that link between internalized stigma and ART. Stigma predicted lower social support and more loneliness, which in turn predicted depression, which in turn predicted suboptimal adherence. In a more elegant analysis, because we know longitudinal studies are methodologically stronger than cross-sectional studies, they show that women experiencing stigma at time one were more likely to have adherence problems at time 3. They assessed women every 6 months in this study, and that was mediated by depression at time 2. So having stigma at time 1 led to more depression at time 2, and if you had depression at time 2, that led to poor adherence at time 3. And this was true even when they controlled for the level of adherence at time 1. So I'd like to give an example for men, and this example comes from the literature on PrEP and PrEP stigma among gay and bisexual men. Your eyes are probably being drawn to this picture here. In 2012, when the FDA approved Truvada for pre-exposure prophylaxis for HIV, there was a lot of negativity in the MSM, men who have sex with men, MSM community, around using Truvada, and this meme, Truvada whore, came up. Really negative, making it a negative thing to use Truvada to protect yourself from HIV. A lot of it was about becoming sexually promiscuous. Why don't you use condoms? We've been working on using condoms for so many years. This is actually a nice ad for someone who wanted to take back the term Truvada whore and get rid of that as a negative thing. So I love this picture because the idea was to counter the stigma against men taking Truvada for PrEP. But there are still a lot of stigmatized beliefs among people about using PrEP. Anticipated stigma, the belief that if you're using PrEP, people are going to think you're sexually promiscuous, that you engage in chemsex, that you maybe have a weak character, and even that you have an STI or for sometimes HIV because it's the same medications that are used for HIV treatment. People experienced enacted stigma, negative attitudes from providers when they asked about getting PrEP or discussing PrEP, negative reactions from partners in line with the above beliefs. Why are you having sex with so many people? And as a result, PrEP stigma has been shown to negatively predict PrEP behaviors, of course. So those behaviors are choosing to adopt PrEP, maybe not adhering to it as much as you need to, discontinuing it before it's a good time to discontinue, and not disclosing to your peers that you are using PrEP. So I'd like to present to you data just from one study that was published recently by Rob Stevenson and colleagues. And it was a large study of 375 cisgender male couples in the US. They were, at least one partner in the couple did not have HIV. They'd been together for at least 3 months. And this was an online sample. So actually they sampled them individually, they surveyed individually, so there were 700 some men. And they asked them about their PrEP beliefs and what they thought about the efficacy. How much does PrEP work? And so they had them complete this survey on the left. I won't read through all the items, but you can take a look at them. There are various beliefs that I mentioned previously. And they asked them to rate how efficacious they thought PrEP was. And the result was that most actually thought and knew that PrEP was effective. 63% very effective, 30% somewhat effective. Most knew that it was effective. Word is getting out. Except at the same time, PrEP stigma was still really high. You could score up to 5 points for every one of these 5 items, so you could get a score of up to 25. The average score was 21, indicating there was still a lot of stigma about PrEP and people who use PrEP. And most everybody said that they were not likely to use PrEP. 37% unlikely, another 23% very unlikely. The researchers looked at relationships between some attitudes and these PrEP attitudes and other attitudes, and they found that people who had anticipated HIV stigma and internalized homophobia, they were more likely to perceive PrEP as stigmatized. But if you had supportive gay and bisexual male friends supporting PrEP, that would reduce your own perceptions of PrEP stigma. So community is really important in characterizing the beliefs about stigma. Okay, so now I'd like to turn a little bit to the work we're doing at CDC. And one of our roles is to conduct surveillance, and we do measure and monitor stigma nationally through 2 of our national surveillance systems. The first one is NHBS, the National HIV Behavioral Surveillance System. NHBS monitors prevalence and trends in a wide range of sexual substance use and behaviors and HIV testing and prevention, including PrEP and SSPs. And until 2019, we were measuring an NHBS community stigma, or your perceived negative attitudes that the community has about HIV. And we also assessed discrimination related to the experience of either being gay or bisexual, a man, or being a transgender person. And I'm going to present some of those data for you. So these are data from the Community Stigma Survey. And these data come from 3 populations: MSM, the one in the middle, people who inject drugs, and heterosexuals in risk communities. And what you can see here, and on the left you see the items. So most people in my area would, and anywhere from 1/2 to 3/4, 2/3 of the people in the groups felt that people would discriminate against people with HIV. Much higher, though, among PWID and heterosexuals than among MSM. In terms of not supporting the rights of people with HIV and not wanting to be friends with HIV, anywhere from a little over 1/4 to 1/3 of folks who were people who were injection drug users and heterosexuals said they thought the community felt that way. This was much lower among MSM. They didn't perceive as much negativity if you were a member of the MSM community. But across the board, in response to the question, people think that people with HIV got what they deserved, anywhere from 19% to 24% agreed with that, and there was no difference between MSM and the other 2 populations. So people are picking up still a lot of negative community attitudes and stigma. This is actually from another study we did looking at key differences in attitudes between Black and white MSM. And particularly in relation to criminalization laws. So this analysis was rooted in a social ecological framework that that considered structural factors like laws and in particular criminalization laws about HIV, that they interact with the community level attitudes towards HIV. And what they found here was that Black MSM reported higher community HIV stigma than white MSM. And very interestingly, Black MSM who lived in states that had HIV criminalization laws, they were more likely to perceive their community as discriminatory towards people with HIV than Black MSM in states without HIV laws. That shouldn't be so surprising, but it just means they pick up the negativity and that they are aware of that. Those laws do make a difference. All right, these data come from the perceived discrimination measures that I mentioned. This one shows data from MSM collected in our 2007 sampling, and this is based on discrimination based on the fact that you are a gay or bisexual man. And we can see that over 1/3 said that they had been called names or insulted. About 15% said they believed they were receiving poor service and were treated unfairly either at work or at school because of being a gay or bisexual man. And this discrimination survey is for transgender women and based on being transgender or gender nonconforming. These are, let me step back. Overall, these are the various items that we asked people about. Overall, 70% of transgender women in the survey reported they had experienced at least one type of discrimination in the past 12 months. And this is the proportion who experienced these various types in the past 12 months. And you can see over half said they had experienced verbal abuse. 1/3 or just over 1/3 said they had trouble getting a job. They had poor service in public spaces. And over 1/4 said they had experienced physical abuse. So transgender women experience a great deal of discrimination. All right, so I want to turn to the Medical Monitoring Project, or MMP. MMP is very important because the measures are somewhat simple, but it produces representative estimates for the country. It's representative estimates of behavioral and clinical characteristics among U.S. adults with diagnosed HIV. So this survey does not look at those living with undiagnosed HIV, does not try to estimate what's going on there. But it's a cross-sectional design. It's collected in annual cycles through individual interviews with patients and matched medical record abstraction. Before 2015, it was the inference population was people who were receiving care, or medical care in the U.S., but in 2015, we were able to identify and add in even those people who were out of care. So the reference population is all adults living with diagnosed HIV in the United States. And that's why one reason this survey is so important to us. We have two scales in here, a stigma scale. It's very general. It's a 10-item scale from 0 to 100, and higher scores mean you're experiencing more stigma in these 4 areas: personalized stigma, disclosure concerns, negative self-image, and perceived public attitudes. In 2018, we added this discrimination in HIV care index to see what was going on there. So we asked people what they experienced in the past 12 months in HIV care, and you can see the list of items and questions they're asked about. We did have an older discrimination index I'm going to mention because I'll say something about some of the data. This was in any health care ever since they were diagnosed, but it has a limited number of items. It does ask people to what they attribute the discrimination. So let me start by talking about the stigma index from MMP. This index is really important because since 2015, the National HIV/AIDS Strategy, or NHAS, uses this MMP indicator as one of its the score is one of its indicators of progress. So it's supporting the NHAS vision that all people with HIV live lives free of stigma and discrimination. Now, these are median scores through 2021. Most recently, we're at 29. And our goal by 2025 is to get to a score of 15.6. I see rounded on this scale up to 16. But that represents a 50% decrease in the reported stigma since we started measuring it in 2018. We've done some research on the stigma index. Our analyses show that there are some statistical differences according to race, and we find that Black and Hispanic or Latino, gay, bisexual men experience significantly higher HIV stigma compared with white MSM, and they had stigma scores that were twice as high as the national goal. So that shows us where we really have a lot of work to do. And finally, this figure shows the distribution of responses within the domains. And just to take a look at it, the 4 domains are personalized, disclosure, negative self-image, and public attitudes. And if you can look at the dark lines are showing where people scored higher. So when you see tall dark lines on the right, that's where they're reporting the most stigma. When you see tall, like light gray lines on the left, that's most people saying they don't. And so what we're seeing here is disclosure-related stigma and public attitudes. Negativity related to public attitudes are where people are experiencing the most stigma, while personalized and negative self-image stigma are less frequently reported. We also found in this study that stigma was associated with lower ART use and lower ART adherence, missed HIV care visits, and depression or anxiety symptoms. This is from our older index. This is discrimination in any healthcare setting. It's among people with recent diagnosis, and we found that about it was 14% said that they experienced some discrimination in healthcare. 82% attributed that discrimination to having HIV. An interesting finding about this study was related to poverty, and you folks from Ryan White will be interested. So poverty was associated with higher discrimination among those who were receiving care at a facility that was not receiving Ryan White HIV/AIDS program funds. Except where homelessness, people experiencing homelessness, that was associated with discrimination regardless of whether the facility was receiving Ryan White HIV/AIDS program funds. And finally, this is the newer index looking at correlates of discrimination in HIV care. 25% of people with HIV who had an HIV care visit in the last 12 months said they experienced some type of discrimination. Oh, the nice thing was it was not frequent. It was not reported as happening a lot, as a rare event. Perceived discrimination, again, was associated with lower ART use, medication and visit adherence, and trust in HIV care and treatment info. We know a lot, and we know where stigma is happening, who's experiencing a little more, a little less, and what type of experiences people have. But the key is to changing that. And how do we change attitudes? And we're doing a lot of work through social marketing. I want to start by sharing a campaign. It's not our campaign, although we contributed to it, that was conducted by the Wisconsin Health Department. It's called Acceptance Journeys. This was a social marketing program in Milwaukee, Wisconsin, that was targeting anti-gay discrimination. The Wisconsin Department of Public Health, with support through one of our CDC cooperative agreements, developed this campaign to address increasing infections in the gay community, particularly among MSM of color. As you can see in the picture, the tagline is, "Whose life could you change with love?" I love that. It pairs photos and stories of heterosexual people declaring their love and their acceptance of the LGBT people in their lives. So in this evaluation, the campaign was done in Milwaukee in 2 matched comparison cities that did not have anti-homophobia campaigns, St. Louis and Cleveland. There was massive social media, print ads, website, press releases, storyboards. I saw it going through the Milwaukee airport. And what they did was they collected data annually online between 2011 and 2015 using a rolling cross-sectional survey. That means they sampled a group, the next year they sampled another group. It's not longitudinal, but they looked at, they drew a different group every year. And each year, a unique sample of Black and white adults who were age 30 and over, they were surveyed in the intervention and comparison cities. So what they found was that, first of all, the message, the targeting of the messages was great because Black individuals and Milwaukee residents were more likely to have seen and been exposed to the campaign. So that's good. If that doesn't happen, you're in trouble. And they found that campaign exposure had a significant relationship with 3 things: perceptions of the impact of stigma on the lives of the LGBT community, perceptions about the community acceptance and need for acceptance among members of the LGBT community, and positive attitudes towards gay men. It didn't affect stereotypes about gay men, but it did have an impact on people's perceptions. And they did not find differences across cities, but they did find that those people who reported increased acceptance of gay men, this was mediated by having made changes in these 3 areas. So changing these 3 areas of belief are really important to addressing homophobia, which, as we know, is an intersecting stigma with HIV. So now I'd like to talk about what we're doing at the CDC in our national social marketing campaign. I hope you've seen it. It's called Let's Stop HIV Together. Originally, this was a subcomponent. Our stigma activities were a subcomponent of our 2012 Act Against AIDS campaign. The first section were some of the pictures. People living with HIV and their family, friends, and loved ones physically close. So just touching people with HIV was an important message about stigma. When we revamped and refreshed the campaign, stigma reduction actually was elevated to a very central focus. As you can see on the right, we're directly addressing stigma and talking about stigma. We're depicting real people and their real life experiences. The pictures are more inclusive, more representative in our imagery, and we talk about stigma in the messaging and in the stories. Why? Why is it important? Now, this is a broad national campaign. It's not just targeted to people living with HIV. And the reason is, in the 2018 administration of the Consumer Style Survey, we found that negative attitudes remained. You can see here that anywhere from 1/4 to 1/2 of individuals, and these are a cross-section of large sampling of people across the country, they responded unfavorably to statements about people with HIV. So these data suggested that myths and misperceptions about HIV, even in 2018, were still an issue within the U.S. So Let's Stop HIV Together is our social marketing campaign directly addressing stigma. I won't go through all these elements here because I might run a little long, but I want to say that it was built on a great deal of formative research as we refreshed this campaign, and we kept things, we increased certain things. Some important things where people said, we want you to provide context when using the word stigma. What does it mean? Don't just put it out there. Provide a direct call to action. What can people do? It's one thing to see this ad, but then so what? What do you do about it? We make that very clear in this campaign. And people really like testimonials, so we do have a lot of testimonials there. This is an area we try to bring towards the public. In addition to our priority audience, we want to say that everybody has a role to play in eliminating HIV stigma. We've worked stigma messaging into the rest of all of our assets across the portfolio as well. So you can see some of the links. I can share those with you. I hope if you haven't been there, you might go to our website and look at our campaign. Part of the goal is to normalize HIV testing and having HIV just like any other chronic condition. We try to emphasize that HIV is just a diagnosis. It's not a person. It's not, the people are living whole, full lives with HIV. So these are some of the ways that we integrated stigma into our campaign. This is the approach for people without HIV. We wanted to educate people, we wanted to address those misconceptions, and we wanted to say how you can play a role. So normalizing behaviors such as testing is really important, and telling people that they can play a role in helping to stop the stigma associated with HIV. We have a massive number of online resources if you go. We have social media, content samples. These are just a couple of examples that you can pull. We have pledge cards. This creates a way to sustain communities that make a commitment to doing something important to reduce HIV stigma. We have some addressing external stigma. For example, she's not my friend with HIV, she's my friend. And we also have some addressing internalized stigma. HIV doesn't define me as part of the approach to addressing internalized stigma for people living with HIV. One more piece on there that I think is interesting is stigma scenarios. These are really dialogues. They're made up dialogues, but sometimes people say something and you don't know what to say. How do you respond? This is a good way of responding in a way that's not mean, it's educational, it's not putting people on the defense, and it prepares you to be able to be an ambassador for reducing HIV stigma. Okay, I want to turn a little to stigma reduction intervention. So I want to change a little to sort of a big activity that we've been doing at CDC since 1996, and it's called our Prevention Research Synthesis Project, PRS. We have been, through PRS, capturing, evaluating, and summarizing the HIV prevention literature in order to enhance our domestic programs that we put out through the health departments, through the CBOs, as well as HIV policy. That we publish in something on the left side, you see here the compendium. And then also through unbiased search strategies and rigorous evaluation procedures, we identify those evidence-based interventions which we put into our compendium, which you can find online. And we also synthesize the broad prevention literature with systematic reviews and meta-analyses. And those, we publish those online as well as in the literature in that systematic review section. So in the compendium, it's officially called the Compendium of Evidence-Based Interventions and Best Practices for HIV Prevention. I hope you've seen it. That's focused on individual interventions that have been tried, usually a trial, and evaluated for efficacy. We publish the results in 5 chapters, and each of the chapters is predominantly dominated by the outcome. So risk reduction, sex and drug risk reduction, we've now added testing in there. Medication adherence, linkage, retention, and re-engagement and care, and PrEP use and persistence. But our 5th chapter, structural interventions, is actually organized by the type of intervention. They're all structural. And in that chapter, we do have stigma reduction as one of the outcomes that could be achieved to show this intervention is efficacious. To date, we have 5 evidence-based or evidence-informed interventions for stigma reduction in that structural chapter. So if you're interested, please feel free to go online and take a look. And we've also conducted 2 systematic reviews directly related to stigma. The first is about the effectiveness of HIV stigma reduction interventions for men who have sex with men. We wanted to see what were the characteristics of these stigma interventions and do they affect HIV-related outcomes. We were able to identify 26 interventions. Most were randomized controlled trials, so they were methodologically strong. But they weren't just interventions designed to just address stigma. They had a stigma component because we really didn't have a body of just trying to address stigma like we do for example, in the campaigns. But we were able to identify 26 interventions with a stigma component. And what we found was these interventions were effective for reducing sex without a condom. Some of these were well before the PrEP era. That was with male partners, that was with female partners, and that was also while under the influence of alcohol. So that's good. We found that there was a slight increase in HIV testing for these interventions, so that's good too. but interestingly, they made no difference in stigma. So people were doing things that they were healthy for them, but we did not see a change in stigma. So again, more work for us to do. And the second review I wanted to mention is a small review of provider perspectives on HIV stigma. This review included 6 studies of practitioners that work in a variety of settings, including correctional settings, in the United States and the U.S. territories. And these were published between 2010 and 2017. And they identify 3 overarching attitudes, which I think are important, even though it's a small number of studies. 3 studies identified 1 or more stigmatizing attitudes towards people with HIV or people who need HIV prevention services. This was primarily among white male primary care providers with limited to no recent HIV stigma training. So training is really important. You can't just expect these things to happen. Education and training also came up. Higher stigma was facilitated by limited opportunities for clinical education or for practice, particularly for non-HIV specialty doctors. So we now, our field was focused on HIV care and HIV care providers, but with PrEP, we're expecting many, many providers to be, helping people get on PrEP and prescribing PrEP. So we need to really address stigma much more broadly. And also, they found that the quality of patient care can be impacted by fears of occupational exposure to HIV. And in line with that, I wanted to share with you some results that are from the DocStyle survey. Again, this is this large web-based survey that Porter Novelli conducts, like 50,000 clinical providers. But here are some findings in 2021 about beliefs about PrEP. 17% thought that somewhat agreed or strongly agreed that prescribing PrEP would encourage patients to engage in irresponsible behaviors. At least some were worried about getting HIV if they gave an injection to someone with HIV, 42%, if they dressed the wounds of someone living with HIV, 57%, or drew blood from someone living with HIV, 58%. So you could see that occupational exposure piece coming through here. And finally, 24% of providers indicated that they had observed at least 1 instance of a healthcare worker providing poor care to people with HIV or talking badly about someone with HIV. So we really have a lot of work to do to broadly educate providers. So finally, I want to talk a little bit about some of our public health strategies that we are really promoting and at CDC. And they're not stigma interventions directly, but I think they have a collateral benefit of reducing stigma. The first is HIV self-testing. I hope you know that we are kind of promoting HIV self-testing because we want to reach people where they are. We want to make it easier for them. They shouldn't have to schlep on into a clinic to get tested or pay $40 in the Walgreens. No offense to Walgreens. So we've been doing research on direct-to-consumer HIV self-test kit distribution, and these are ways to help people learn their HIV status in the privacy of their own home. And what it does is it removes that anticipated stigma, oh my God, what are people going to think about me when we go in, and enacted stigma, anything that someone might say to somebody when they come in to get HIV tested. Our research in 2 studies that we did, eStamp and iStamp, show that HIV self-testing delivered through the internet is effective, convenient, accurate, cost-saving. And in our follow-up study, we can even reach disproportionately affected populations who've never tested for HIV. That's the population we really wanted to reach. So in 2021, we did a pilot project called Together Take Me Home, which was a national distribution of 100,000 free HIV self-test kits through the mail, and it was so successful that in 2022, we funded a mass mailing project. This has a program component and a research component, but it's a multi-year project, and there is a research part. This was funded to Emory University. You may have heard of this study. Right now, we're exceeding expectations for the demand on self-test kits. Again, this is all no touch, no contact, just through the internet and through the web. 320,000 test kits have been distributed as of about a week and a half ago. So that's a way of removing stigma associated with testing. I want to talk a little bit about telemedicine. Of course, Everyone's doing telemedicine now in the post-pandemic, COVID pandemic era. But prior to COVID, most of the telemedicine and HIV was done with respect to people living in rural areas. It was a very far distance for them to get to a clinic. There were not providers that were close to them. But we realized that people have a lot of barriers getting to their clinic appointments, even if they're living in a city where they don't have to, travel thousands of miles. But they have to take off of work, deal with traffic. Many had to take like 2 buses, and it would take a long time, childcare, et cetera. So we funded this demonstration project, 17-17-10. I put the number there just so you know. It was pre-pandemic. We were on this pre-pandemic. And it was to look at telemedicine and its effects on retention and appointment adherence among clinic patients in an urban setting. So again, this was not a study. It was a demonstration project, but we did focus groups afterwards about what people liked about it, if they participated. And what really just jumped out at us is people weren't talking about the time or the childcare costs or the buses. They were talking about stigma. They said, a lot of people said that it was just so nice not to have to walk in that HIV clinic where they felt people looked at them, they knew what they were there for, they were aware. And I have just a couple of quotes here. People look at me really crazy on that 3rd floor. I'm sure they know what floor or why I'm going there. And one of the providers we interviewed said the other thing I've noticed is that a lot of our patients who have problems coming into the clinic, they fear being recognized by someone else in the clinic. Could be someone who's another patient, or it could be someone who's who works there. So coming into the clinic is really a stigmatizing experience if nobody does anything negative. And so the push to integrate telemedicine that's come following COVID-19, I think really is going to have stigma reduction benefits. And finally, I want to talk about whole person care, or this is something you've probably heard of as status neutral care and service delivery models. We're sliding away a little bit from the term status neutral because we learned that some people don't like this term, but really all it means is whole person care, where you integrate health services for prevention and treatment into one location and one primary, comprehensive primary care location. That's because stigma is embedded in the experience of many people who are seeking treatment and prevention services, particularly limiting people who don't want to come to someplace labeled STD testing or HIV clinic. And so when you address the whole needs of a person, it starts with a test. If you're HIV negative, if the test is negative, you're not negative, the test is negative, then you start helping the person stay negative. What do they need? Do they need PrEP? Do they need housing support? Do they need other sorts of financial help? And if a person tests positive, then they need all those same social determinants of health addressed so they can stay on their medication and stay virally suppressed. So the goal of status neutral care is really to integrate those things to address the whole person, including their social service needs, to keep them on whatever care they need to be on, and reducing stigma as a benefit. All right, so I'm just going to finish up a little bit about language and what we say and how what we say matters. And I have on the right here this something called the DHP, that's the Division of HIV Prevention, Correct and Preferred Usage. This is an internal guide that we use about language. I can't share it because the internal hasn't been cleared. But on the left is a CDC guide that has, it's not HIV specific, but if you're interested in finding one, you can go to this link for Health Equity Guide, which comes broadly from CDC. But here in DHP, our division, we're working hard to use first-person language. So we don't say IDUs anymore, injection drug users. We say people who inject drugs. We don't say homeless people. We say people who experience homeless. We really want to take the stigma out of that. And we are limiting some of our risk-related terms because we realize those could be stigmatizing as well. So instead of at-risk people or high-risk populations, risky behavior, we're going to talk about risk factors that someone may have or behaviors that increase their chance of getting HIV, people whose social determinants of health increase their likelihood of getting HIV. We're really trying to look at really destigmatizing some of our language as well. We do have a stigma language guide that's associated with the Together campaign if you're interested. And then finally, I'm going to end by saying that We think it's important to listen and learn from the communities that experience stigmas related to HIV and all the intersecting stigmas that impact the populations that we work with. We have, for the last 2 years, been having community conversations, public engagement sessions. This year, we're doing them together with HRSA. And I just wanted to mention that we think it's important to hear from people with their lived experiences. And we are coming to a place not here, but look, not far from you. So we will be in Baton Rouge in February, and we hope you come out and share your perspectives and your thoughts with us. So with that, I'm going to say thank you, and I would be happy to answer questions.
It's a pretty basic question, but I noticed in your language card you use people with HIV instead of people living with HIV, and I just wanted to know if there was like any research behind that or what.
Yeah, that's important. That's a good question. We were saying people living with HIV, and at some point, some of us started saying, as opposed to dying with HIV? Like, it seemed like we no longer needed that living. It was just, here's a virus you have, like you could have this illness or that illness, you're living with HIV disease, but we don't use the living term with other things, and so it felt like it was like shining a light on dying with HIV, and we just sort of decided we didn't really need it. So we evolved.
We previously never had opportunities or resources to do target marketing. And so tomorrow actually marks a 1-year anniversary of our Bounce to Zero campaign. And so I want to get an idea from you. What are some recommendations and strategies that you have to engage community members and to show the successes of the campaign?
You know, I think a lot of times just having, like, we do a lot. I think I actually mentioned this not in our campaign, but when I was talking about acceptance journeys, all the places you put things. There are billboards, there are things in bus, stanchions, sometimes in papers. So I think getting it into a lot of locations, they have done research about where people see things most, so they try to put them in places. There are little QR codes that people can scan. They look where people are scanning from. And so there's ways to sort of assess where people are accessing the information. I think it's important. The other thing that I think is important is there's a lot of community mobilization kinds of events that also help public social marketing campaigns be successful. I can't, off the top of my head, remember this review, but I know that there has been one or more reviews talking about the benefit of having mobilization campaigns, which are events where you share things. For the efficacy of social marketing campaigns. So I think you have to think about not just, an ad here or there, but really how to saturate the locations where you want to reach people.
I'm just wondering if the CDC is conducting more research into harm reduction with SSPs and transmission rates. Specifically, I'm looking for Louisiana data. I haven't really been able to find that.
I don't know where the Louisiana data is, but let me go to the first question. I guess I need this. We have a lot of activity around SSPs right now. It's actually conducted or coordinated out of our center. We do have a surveillance. Part of NHBS is doing a surveillance study on use of SSPs, types of SSPs, variations, and how they work. That's, I think, our first surveillance study on SSPs. But there's a lot of work that's coordinated out of our national center, which is NCHHSTP, which is the National Center for HIV, Viral Hepatitis, TB, and STD Prevention. And viral hepatitis actually is leading a lot of that work. So we have a harm reduction, a call center, and we have learning collaboratives. I believe that we have TA providers who are actually there to provide, SSPs are teeny or big, right? Some have more issues that are political. They come and go or move around with how the politics of the time are. But I think it was felt like having a national sort of center where people can get guidance was really helpful. We were doing that in collaboration with our injury center, the National Center for Injury Prevention and Control, which is where our opioid and overdose work is, and with SAMHSA. So it was our center, Injury Center, and SAMHSA. And then the reason I don't know as much about it recently is because it was moved to be led out of the Injury Center, but our center is still very involved. We do collect data. We do have data for the states, and I can, if you give me your name, I can see if I can find out how to find your local Louisiana data for you. But we are definitely still doing surveillance, and we're doing more. I can't call it researchy because it's not research. It's not approved as research, but information collection as part of that surveillance on SSP, so we can learn more about it. Thank you so much.